Okay. Okay. So we're continuing our tour of first trimester anatomy, and my fetal therapy today is on first trimester cardiac images. I think everyone here knows me, but if anyone doesn't, my name is Jenani. I'm one of the second-year MFM fellows here. So the focus of this talk is not cardiac embryogenesis, but we're going to briefly touch on it. Briefly, the heart starts as a tube-like structure that then undergoes significant folding to result in this recognizable four-chamber with the truncus that kind of divides into your pulmonary artery and your aorta. And if we go through the stages of cardiac development along with gestational age, which is listed here at the top, we can see that significant cardiac development is still happening into 9 weeks gestation. So caution is advised with doing detailed cardiac imaging when you're less than 10 weeks, but all the images we're going to go over today are further along than that. So in terms of first trimester anatomy and like when is the best time to perform this scan, your y-axis is your frequency of detection and your x-axis is your gestational age. And you can see that it kind of levels off between 12 to 13 weeks. And our sweet spot is kind of in here, 12 and a half to 13 and a half weeks. So that would be the ideal time to do this scan. So while many of the views we will discuss today are part of the AIUM protocol that Dr. Al-Kwatli and I are working on bringing here, there are some other reasons to focus on the heart in the first trimester, such as if you have an increased NT, if you see reverse flow in the ductus venosus, if you see any tricuspid or mitral regurg, if there is an abnormal cardiac access, if there's any other suspected abnormality, or in a patient who has obesity. And then looking at data for nuchal translucency, we can see that as the nuchal translucency increases, which is on your x-axis, the prevalence of congenital heart disease also increases, which is on your y-axis. A lot of centers use the cutoff of like 3 to 3.5 to recommend a fetal echo, and it kind of goes along with this trend showing that as you move up in your NT measurement, your prevalence of CHD increases. So when we think about cardiac imaging, the key is image optimization. So I'll preface this talk by saying, I talked to some of the fellows about this as well, but Dr. Abu Hamid's first trimester ultrasound book, as well as his echo book, are excellent sources. The way that they go through things in a systematic way is very easy to learn from. And many of the pictures today are from both of those books, as well as the tables. So this is actually from his echo book, but the same idea kind of applies to your first trimester. You want to have your fetus in dorsoposterior position. So basically that NT position, you want to magnify your image. You want narrow sector width, which helps improve your frame rate. You want the fetal thorax to occupy 1/3 of the ultrasound screen. And you want to use the high contrast image settings, and then use a mid to high resolution transducer. And you want to scan from apical to the right lateral of the fetal heart. This table is also from his book. So you want to start with grayscale optimization before activating your color Doppler, as we do usually. And then you want to use a narrow color Doppler box as small as possible. That will also help improve your frame rate. Using mid velocity color Doppler range, use mid filter levels, use mid to high resistance, use low colored, and then you can also use low color Doppler gain, low output, and use bidirectional Doppler, which is also called high definition Doppler if available. So talking about high definition Doppler, this is an image of a fetus at 13 weeks. And on the left is your conventional color Doppler. And on the right is the same fetus with the high definition. And you can just see that your image just looks much better in the right, and it's much easier to see and much clearer. So in terms of the approach, there's a lot of debate about transvaginal versus transabdominal. The truth is it really depends. Transvaginal, there are some pros and cons. The pros are you get better resolution, you are closer to the fetal heart. The cons is it's inconvenient for the patient. There's a limited range of motion with the probe, and it requires sonographer experience. Our sonographers are really good at looking at things transvaginally, so I think it wouldn't be as much of an issue for our center, but just thinking about many other centers that may try to implement this, it may be an issue there. And like we talked about before, the most optimal time is kind of in that 12.5 weeks or 13.5 week range, and you want your fetus in transverse lie. Dr. Abu Hamid has mentioned that his center starts transabdominally and then they move transvaginally if they're unable to complete the study. So in terms of your transverse lie, when you have your fetus laying like this, it gives you really easy access to your NT, and then you can see your cardiac views transvaginally if you need to. So in terms of the important views that I'm going to talk about, there's the abdominal situs, the 4-chamber, you want to see your pulmonary veins, and the outflow tracts. So in terms of abdominal situs, we do it the same way that we do at the anatomy scan. So you start with the stomach, which is on the left, and you just sweep up to get your 4-chamber view, and you want to make sure that they're both on the same side. In terms of your 4-chamber view, this is going from 9 to 11 weeks gestation. And you can see how like 9 weeks and 10 weeks, it's kind of hard to make out. Like if you squint a little, you can kind of see it. But at 11 weeks, it starts to look a little bit more familiar, like the 4-chamber we're used to seeing at the anatomy scan. And then definitely from 12 weeks onward, it looks very familiar. So you want to see your 4-chamber view with your 2 atria and your 2 ventricle that appear normal in size, and then you add your color Doppler, and that helps you see if the axis is normal, and I'll touch on the cardiac axis at the end of the talk. And then the video clips can also help you show equal filling and contractility, which are also both important. So if you want to image your pulmonary veins, you want to reduce your color velocity and increase your gain, and reduce your filters, and you just adjust your angle of scanning. And I have a picture of this. This is an example at 13 weeks where we use low color velocity and increase the gain. But that helps you see your pulmonary veins. In terms of the outflow tracts and when you can see them, your x-axis here is your weeks of gestation. Your y-axis is the percentage of fetuses where they were able to see this. And you can see once you get past 11 weeks, you can definitely see your aortic and pulmonary outflow tracts, your outflows, and especially when you add on color, it's much easier to see. So this was a transvaginal scan of the outflow tracts with color Doppler at 13 weeks. In A, you can clearly see your LVOT. In B, you can see your pulmonary artery. And C is your 3-vessel trachea view. And while you can clearly see the LVOT in A, it's actually very difficult to obtain in the first trimester, and it's not as useful or helpful in the first trimester, but comparatively, the 3-vessel trachea view is very helpful. You can see your pulmonary artery, your ductal arch, and aorta, all to the left side of the trachea with forward flow, and all equal in size, which is important. So in terms of the 3-vessel trachea view and screening for congenital heart problems, this was a study that looked at around 5,300 fetuses. They looked at trying to see if they could get the 3-vessel view, and it was feasible in 94% of cases, which is pretty good. And it helped with a detection rate of 76% of congenital heart diseases that developed in these fetuses. So this kind of highlights how important it is to get this view and how feasible it is if they're able to get it in 94% of cases. And then to touch on the aortic and ductal arches, this is also an image from 13 weeks. This doesn't really add much to your cardiac screening beyond the 3-vessel view because they're so close to each other at this gestational age. And you can see them in the same plane as you can here. And here you can see both in the same image. So just a quick summary of our 4 views. Again, in A, you have your abdominal circumference, and then you can also add color to help determine your situs and look for the SVC and IVC. In B and C, you have your 4-chamber views with and without color. And in D, you have your 3-vessel trachea view. So these are kind of the 4 views that are important to get. So now that we've reviewed some of the normal views, I wanted to talk about some of the abnormalities that we can see in the first trimester if we look. So kind of the format is going to be like the cartoon image and then the ultrasound image. It was helpful for me to see both, and I hope it'll be helpful for everyone here as well. So first, we're going to talk about hypoplastic left heart syndrome. This is a group of complex cardiac malformations involving significant underdevelopment of the left ventricle and the LVOT, resulting in obstruction of the systemic cardiac output. So there are two main forms that can be seen in the first trimester. In A over here, you have atresia of both the mitral and aortic valve with no communication between the left atrium and left ventricle and nearly absent or severely hypoplastic left ventricle. And in B, you have a visible left ventricle with a hyperechoic wall, globular shape, poor contractility, and this is in association with a severely dysplastic mitral valve combined with a severe aortic stenosis or aortic atresia. So these are the ultrasound images at 13 weeks. In A, you can see the left ventricle is very small. In B, you can see no blood going across the mitral valve. And in C, you can see reverse flow in the aortic isthmus in the 3-vessel trachea view. And this is version B. So this is the ultrasound images of the second form that we touched on with the cartoon. So in image A, you can see the dilated ventricle that is hyperechoic with the septum bulging across into the right ventricle. And in B, you see no flow across the mitral valve here, but you can see it from your right ventricle. So next, we're going to talk about coarctation of the aorta. This usually involves narrowing of the aortic arch, typically located at the isthmic region between the left subclavian artery and the ductus arteriosus. This is a common anomaly. It accounts for about 5 to 8% of congenital heart disease, and it can be classified as simple when it occurs without important intracardiac lesions and complex when it occurs in association with significant intracardiac pathology. So overall, you'll see similar things to what you would see in the second trimester, including ventricular disproportion in the 4-chamber view and a narrow aortic arch in the 3-vessel view. This is very rare to make this diagnosis in the first trimester, but still something that is important for us to know. In terms of atrioventricular septal defects, this represents a cardiac abnormality characterized by a deficient atrioventricular septum and abnormalities of the AV valves, primarily resulting in the presence of a common AV junction. In the complete form of this, there's a combination of atrial septum primum defect and an inlet VSD with an abnormal AV valve, which connects the right to the left ventricle, which we can see here. So this is actually commonly diagnosed in the first trimester. And the biggest clue is when you put on your color Doppler, you'll see what they call this H sign here. So you can trace out an H here as well as here. And then other important signs are seen with video clips with regurgitation and systole. Next, I wanted to talk about Epstein anomaly, and this is when you have the septal and posterior leaflets of the tricuspid valve that are displaced inferiorly from the valve annulus towards the apex of the heart. And then here in ultrasound images, you can see that your right atrium is dilated only in severe cases. Your color Doppler will show the significant regurgitation jet, and then when you Doppler that area, you can see Doppler flow of the regurgitant jet across a dysplastic tricuspid valve. So tricuspid atresia with a VSD is characterized by the absence of the right AV connection, and this results in lack of communication between the right atrium and the right ventricle. A VSD, typically perimembranous, is always present, and the size of the right ventricle is related to the size of the VSD. A large intraatrial communication in the form of a patent foraminovalle or an atrial septal defect is necessary because you have this obstructed tricuspid valve. So this is the ultrasound image of this. And then at 13 weeks, you can see there is filling across the mitral valve with no filling across your tricuspid valve. And then in B, you can see the associated pulmonary stenosis as the pulmonary artery appears much smaller than the aorta. Next, I wanted to talk about univentricular heart or univentricular AV connection. And this is a group of cardiac malformations where the AV connection is completely or predominantly to a single ventricular chamber. From a clinical point of view, when you have a univentricular heart, it basically describes one heart. It describes a heart with one functioning ventricle with inflow from one or both atria. And here we can see it's coming from both atria. So in terms of the ultrasound images in A, you can see the left and right atrium coming together into this single ventricle. And then in B, you can see two jets coming through the respective AV valves. So VSDs, which we commonly see in the second trimester, are generally too small to reliably be isolated anomalies in the first trimester. So caution should be made in making this diagnosis. Given the significant false positive, which is usually due to dropout in 2D ultrasound and color overlapping when using color Doppler. But in most cases, the VSD is reliably demonstrated when it's associated with another cardiac anomaly. So if you see something else, it's important to also check for a VSD. Or if you see that your 4-chamber view is abnormal, it should increase your suspicion for a VSD. So in A, we have a fetus with tetralogy of Fallot at 13 weeks gestation, and you can see the presence of a perimembranous VSD. And then in B, you have a transverse 4-chamber at 12 weeks with a muscular VSD. So tetralogy of Fallot is characterized by a malaligned aortic VSD, characterized by a malaligned VSD, and then you have your aortic root that overrides the VSD, and then infundibular pulmonary stenosis, and then right ventricular hypertrophy. And then with ultrasound images, this is at 14 weeks. In A and B, you can see that there's left axis deviation. In C, you can see the overriding dilated aorta over the VSD, which is represented by this star. This is also called the Y sign because you can see the blood coming from the left and right ventricle. And then in D, you have your 3-vessel trachea view showing pulmonary stenosis with a smaller pulmonary artery compared to your aorta if you look at the width of these. Next, I wanted to talk about double outlet right ventricle. This is a family of complex cardiac malformations where you have both of your great arteries arising primarily from what is morphologically the right ventricle. So here you can see the pulmonary artery and your aorta arising from your right ventricle, and you can see that there's a VSD here as well. And then in B, you can also see the pulmonary artery and the aorta arising from the right ventricle in the 3-vessel trachea view. So common arterial trunk is characterized by a single arterial trunk that arises from the base of the heart and gives origin to the systemic, coronary, and pulmonary circulation. A large VSD is almost always present with this anomaly, resulting from the near absence of the infundibular septum. So this is at 13 weeks and 2 days. You can see in A and B the bifurcation of the common arterial trunk into the aorta and the pulmonary artery. And you can also see that the aortic arch courses to the right of the trachea. As you can see, your trachea is not in the right position that you would expect to see it in your 3-vessel trachea view. In terms of transposition of the great arteries, complete transposition is a common cardiac malformation with AV concordance and sorry, was there a question? Okay. Is everyone muted? I think I can hear myself echoing. Okay, I'm going to keep going. So complete transposition of the great arteries is a common cardiac malformation with AV concordance and ventricular arterial discordance. So this means that there is normal connection between the atrium and the ventricles, which we can see here. And the right atrium is connected to the right ventricle through your tricuspid valve, and the left atrium is connected to the left ventricle through the mitral valve. But there's switch connection of the great vessels. So you can see that your pulmonary artery is arising from the left ventricle and your aorta is arising from the right ventricle. So the best way to diagnose this is through the three-vessel trachea view. So in this three-vessel view, in A, you have presence of a single great artery of normal size, and this is representing the superiorly located aorta. And then when you get more of an oblique view of the chest, you can see the parallel coursing of the great vessels in discordance with the aorta from the right ventricle and the pulmonary artery from the left ventricle. So the next one is going to be right aortic arch. Lean kind of talked about this last week with her ultrasound findings, and I think it's very impressive that this looks kind of exactly the same in the first trimester, which is cool. And then these are just schematic drawings of the different views that you can see with when you have a right-sided aortic arch, this one kind of being the more common thing that we see. So when you get your three-vessel trachea view, this is a fetus at 13 weeks, and you have a right-sided aortic arch with left ductal arteriosus. So basically, this is your U sign, and this is on transabdominal, and then this is transvaginal. And the big sign is that you see your trachea that isn't in the right place. So lastly, I kind of wanted to touch on cardiac axis. I think this is something that is like one of the easier things for us to start doing and start picking off. And I'm going to show some data about why it's a good thing to start doing. So in the first trimester, it's similar in orientation to what we see in the second trimester. So 45 degrees plus minus 20 from 9 weeks onward. And then HD color is helpful here because it can highlight where the septum is. So this was from a case control study looking at the fetal axis between 11 to 14 and 6 weeks. And they looked at 197 fetuses with confirmed congenital heart defects. And then their control group were normal fetuses with similar crown rump lengths. So x-axis is your crown rump lengths and y-axis is your cardiac axis in degrees. So a normal cardiac axis was 30 to 60 degrees, and then blue circles are showing your control group, and red triangles are the fetuses with congenital heart disease. And we see that there is a significant cardiac axis deviation with abnormal fetuses. As you can see, there's many more red triangles up here, and more of your blue circles are down here. So just like a nice visual representation of that. And then in terms of combining your NT with that, so the focus here on this last line, and regardless of whether you use NT greater than the 95th percentile, which is what we do, or if you're just using 3.5 millimeters, you're only picking up some of these cardiac issues, like you're getting 20% and 10%, but when you're looking with the cardiac axis, you can pick up around 70% of them. So far more compared to just using your NT alone. So you can see that the cardiac axis in this image is normal. So it's this blue arrow. With normal heart anatomy, the axis is normal, but in fetus B, you have an atrioventricular septal defect and the ventricle disproportion with aortic coarctation, and the cardiac axis is deviated with a wide angle. So you can see that this looks very different from this. So in terms of what are like written in the guidelines and what are the views that are important to get, based on the AIUM and SMFM guidelines, it's cardiac position and axis, 4-chamber view with and without color, and then your 3-vessel trachea view with color. So important pearls are optimize your grayscale and color Doppler. Color Doppler is really, really important for diagnosis. Important is the 3-vessel trachea view is very important. As you can see from a lot of the examples I showed, like a lot of the times your diagnosis is coming from your 3-vessel trachea view. Looking at the cardiac axis can help increase your detection of heart problems. And most cardiac malformations have similar features in the second as they do in the second trimester. So it's kind of images that we have seen in the second trimester, just in the first trimester. And that's everything. Does anybody have any questions? In terms of bringing this here, I'm meeting with the sonographers on Monday to go over my last fetal therapy with them. And then I'm working with Dr. Al-Kawatli on a protocol to try to do this here.
Well done, Jenani. I guess this will be integrated in a first trimester and early scan protocol, which is great, and I'm happy that you're working together with Huda and the sonographers so that we can have their buy-in, and I think this will be extremely important. Can you and have you talked? I suppose you have talked with Shubi, our pediatric cardiologist, about this, or?
I haven't.
It should be good to be, to be involved. I'm sure she like this. One of the issues that comes up sometimes is false positives, and I don't know if you got a sense from your large, extensive review. I that's the only negative I can see. I think there is 99% positive, and I'd like to see this done. Any comments in particular for cardiac false positives?
Yeah, I mean, especially with the VSD is what kept coming up as like having a higher false positive rate in the first trimester. And the huge disclaimer to all of these studies is this should all be followed up with a second trimester anatomy to like confirm what you're seeing in the first trimester.
Yeah, it's all, and it's all in the counseling. If you counsel that, you see a VSD, but it's very common early in pregnancy, and you don't scare the woman. I'm okay with that, but that's early. It's like when we started doing transvaginal ultrasound for cervical length. Now everybody's a low-lying placenta, and maybe we have increased the diagnosis that really it's not that much of an issue, and it's, if we reassure people, tell this placenta will move up and it's not going to be an issue. If we present VSD, early VSD the same way, I don't think we'll do much harm. Any other comments for Jenani?
I guess I had a question as well, just kind of thinking ahead about how we would counsel these patients. I know that that's going to be an important part of, implementing this. Is just with respect to like referrals to genetics and to discuss the possibility of diagnostic testing. Obviously, if there's an increased NT, there would be a stronger indication for that. But curious to know if we've given any thought as to how we would approach that.
Yeah, so I actually have one more slide that I put at the end in case the genetics things came up. This was, I don't have a reference for this. This was a screenshot from a lecture I watched, but they looked at like genetic testing for when they did have a congenital heart disease, and when they found like looking through karyotype and then microarray, and then like breaking it down into whole exome, and whether there were single gene disorders found, in whether it was isolated or non-isolated. So I think this will be helpful for our counseling. I will try to find like a paper or a reference for this, which will help us as well.
Great, thank you.
Yeah. Thanks, everyone.
Thanks, Jenani. I see that Kola is with us.